Okay, thank you very much for inviting me. Probably in a cardiology conference, this is actually a sort of surrogate topic, but nevertheless, I think it's still very interesting. I'll talk to you about managing chronic pain in the leg and foot. To start off, I want to show you this slide, lesson of the week, a painful red foot. So this is actually a foot that is red and yet ischemic. And this was published in the British Medical Journal 25 years ago. In fact, they had a series of cases of a red ischemic foot, which is really ironic, and some of the doctors were caught. And some of these doctors landed in medical legal issues because they're treating ischemic foot with antibiotics for a long time, and then that became a big issue. And we still see this. Fortunately, our patients present a bit late, and most of the time, ischemic foot, you can actually pick it up. Like this patient, he actually has got gangrene at the tip of the right second toe, and foot also look a bit cyanosed. So I think you can actually pick up peripheral arterial disease quite easily. So important thing about peripheral arterial disease is that it is a polyvascular disease. You can always pick it up because when a patient comes to you, if they have those risk factors of age, hypertension, diabetes, hyperlipidemia, etc., so you have to be cautious. If they come with a leg pain, there can be a few things. One is maybe if they've got ischemic limb. The other thing, they could have a peripheral neuropathy. Other things like gouty arthritis, osteoarthritis, etc. These are the possibilities, but you always need to rule out something that you need to treat. The other issue is that if they come with peripheral artery disease, the peripheral artery disease actually is a mirror that tells you that this man has got other issues also. Maybe they've got coronary artery disease or cerebral vascular disease that you really need to be careful about. So what about the prevalence? This actually, we haven't got a prevalence in Asia, and certainly not in Malaysia on peripheral artery disease. But based on the American data, you find that at the age of 70, if you're African American, about 20% of people have got peripheral artery disease, 20%, which is 1 in 5. But with the prevalence of diabetes in this country, about 20%, I think the incidence of PAD is coming up, and I think perhaps probably up to 10% of your patients with all these risk factors, they may have associated peripheral artery disease. Again, to remind you that if they come to me with a peripheral artery disease, I'm always conscious that they may have associated the disease in the coronary artery, and most of them actually need some kind of a cardiac assessment. This slide just to show you that peripheral artery disease do not only affect the lower limb, it can affect the upper limb. However, peripheral artery disease in the upper limb is very uncommon. If a woman comes to me with bilateral gangrenous fingers, more likely that she has some kind of arteritis, such as maybe scleroderma or SLE and things like that. Peripheral artery disease does affect the upper limb, but upper limb has got very good collateral circulation, so usually they don't manifest as gangrene. So in peripheral artery disease, they can be asymptomatic, or they can present with claudication, or they reach a stage, we call it critical limb ischemia, which is acute on the chronic limb ischemia. And you may ask me, if they are asymptomatic, how do you know? Well, they are asymptomatic because they have gone to see the cardiologist, and they want to do some kind of PCI, then they palpated their pulses, radial pulse, no radial pulse, no femoral pulse. Then they realize that this patient has got some peripheral artery disease and was referred to a vascular surgeon for assessment. Important for us to understand the natural history. This is a very busy slide, but you just need to know that when a patient comes to us with peripheral artery disease, with claudication, we are not too worried about the patient. Because if you follow up the patient for about 5 years, only about 5% of patient has got a risk of losing the leg. But if you follow up the patient for 5 years, up to 10 to 15 a patient will have some kind of coronary event. So more importantly, that you have to treat their heart rather than treat the leg. So in leg, what happens is we put the patient on best medical therapy, as you know, anti-lipids, antiplatelets, etc. More importantly, they have to control their hypertension, diabetes, stop smoking, and do some kind of exercises. And peripheral artery disease, like I say, is a reflection of your coronary artery disease and cerebrovascular disease, because if you follow them up for 5 years, if they have peripheral artery disease, compared to a normal population, the risk of death is very much higher if they have got a critical limb ischemia and also intermittent claudication. And when you do ABSI for this patient, means you measure the ankle pressure versus the breaker pressure. And if the patient has got a very low ABI, the odds of cardiovascular events increases dramatically. So it is a good thing that your peripheral artery disease actually reflects on the coronary artery disease. In my earlier days in university, I was trying to do look, maybe by looking through the eye, you might be able to know the coronary artery status and also peripheral artery status. It's a romantic way of looking at things. However, you find that many people come to us, we want to do some kind of funduscopy for a patient. It's not possible, they have cataract, and they won't agree for us to dilate the pupil, etc. However, if you are able to do ABSI for a patient, it's actually a good way. From the leg, you can actually look at the heart. So what are the signs and symptoms? Well, they may present intermittent claudication. Maybe they can walk for about 100 meters and now they get leg pain consistently. The thing has deteriorated. Now they walk 50 meters, they get leg pain, and now at night they can't even sleep. Because once they lie down with the leg up, you find that leg pain occurs. So you know they reach a stage of critical limb ischemia. They may have coldness, maybe color changes, numbness, and maybe ulcer and gangrene. But then how do we pick up peripheral artery disease in population at large? How do we know? So really it's important that if these patients are at risk, if they have these risk factors, their age, hypertension, diabetes, or maybe with coronary artery disease, we have to be aware they may have associated peripheral artery disease. So the simple thing you can do is take a proper history, and then always ask the patient to take out the shoe, take out the socks, or maybe the slippers or chapel, and try to feel for the pulses. And you can't feel the pulses, well, maybe you know the pulses are not there, or maybe you're not quite sure. But what you can do is you can actually do a Doppler. So when I speak to some doctors about this Doppler, they say, no, this machine is very expensive. How am I going to get a Doppler in my clinic and all that? Well, your handphone probably costs about 5,000, 7,000. This Doppler costs 2,500. So you can easily keep one in your clinic, and it's a very simple device. And these days you can even get a duplex scan using a handphone. Just buy a probe. They probably cost you about $1,500. You download the program, you can actually do a duplex scan. Now technology is so advanced that these days we can actually equip ourselves with many technology the way we manage patients in the clinic. And see, this Doppler is quite easy. If you find that you measure ankle brachial systolic index, it's low, then you know that patient has got peripheral artery disease. At the same time, if you have a duplex scan, even better, you can see there's a triphasic in a normal artery, and on the right hand side you find that there's a low amplitude or maybe attenuated flow. Then you know that patient's artery is in trouble. Well, when you reach a stage of chronic limb-threatening ischemia, the patient has got now rest pain, gangrene ulcer. You can actually measure ankle pressure, you can measure toe pressure, you can actually do a transcutaneous oxygen tension measurement, or you can do simple, just do ABI or ABSI, ratios less than 0.4. Now, when a patient reaches this stage, if you do not treat the patient, or just manage the patient medically, in about 5 years' time, half the patients will lose their leg or lose their life. So you really have to intervene at this stage now. So what do we do? With a patient with a gangrene like this, I think the pulses are not there. There can only two things that happen to this patient. It's either ischemia or maybe just peripheral neuropathy. In peripheral neuropathy, you can go on to maybe take out a toe, but if the patient has got ischemia, you take out a toe, you actually increase the portal for entry for the bacteria to come in, and so it will deteriorate very rapidly. So we must try to revascularize this foot before we take out the toes. Just just to give you a normal anatomy of the lower limb arteries, you find that you've got a femoral artery going down to the leg. You've got 3 arteries there. You've got posterior tibial, peroneal, and anterior tibial artery. And these days, you can actually do a simple this is a CT arteriography for a patient. You can actually rotate. You can actually look around, look at the artery. And this patient on the left-hand side, you can see patient has got a popliteal artery aneurysm. So this is actually the Society for Vascular Surgery lower extremity threatened limb ischemia classification. Those days we actually use this Fontaine classification and Rutherford classification, but it's not very good. These days we can actually look at the patient on the wound in a wholesome manner. So it's called a Wi-Fi system. We look at the wound, we look at the ischemia, and also we look at the foot infection. And in this way, we know exactly what to do with the patient. Now, patient may have a very severe ischemia, but maybe just present with gangrene. Then we can just try to overcome the ischemia, and then maybe the foot will heal. However, if the patient has got very bad foot wound, maybe just a stenosis, you find that there's too much tissue loss, and so you can't salvage the foot. So this Wi-Fi classification that we are using now. And basically, you look at the wound, it's a very simple grading. Grade it into 0, 1, 2, 3. And no ischemia based on the ABSI, again 0, 1, 2, 3, depending on the ratio of ABSI. And also look at the infection, whether it's just mild infection or very severe infection. And based on this Wi-Fi classification, we can now decide how to treat this patient. So often I was asked this question, which is better? Do you think endovascular is better or open bypass surgery is better? Which is better? So, well, there have been many trials that go on. One of the trials that actually go on is, they call it the Basil study, bypass versus angioplasty in severe ischemia of the limb. This is actually published in the Lancet. They look at vein bypass first versus endovascular therapy. This trial basically done in UK. And in the summary of this trial is that in the Basil trial, a best endovascular treatment first revascularization strategy was associated with a better amputation-free survival, which was largely driven by fewer deaths in the best endovascular treatment group. So Bradbury concluded in Lancet that maybe endovascular therapy is better because patients less risk of death in this group of patients. However, a larger study done in the US, this international study, look at surgery or endovascular therapy for chronic limb-threatening ischemia. They've got a large population here, maybe 1,800 patients, either assigned to bypass first or endovascular therapy first. And so their primary outcome is adverse limb event or death. So they got 2 groups of patients. One group is a good great saphenous vein, you can use bypass. The other one has got without good great saphenous vein for bypass. And they have, in surgery, they have about 709 patients, endovascular 711 patients. It's a large group of patients. And the hazard ratio is 0.68. So you find that surgery, if you have a great saphenous vein, actually surgery is better compared to endovascular. But you haven't got a great saphenous vein, either surgery or endovascular, they're actually comparable. So in conclusion, in this BEST CLI, critical limb ischemia trial, they found that among patients with critical lower limb ischemia who had adequate great saphenous vein for surgical revascularization, incidence of major adverse event or death was significantly lower in the surgical group compared to the endovascular group. However, if there's patients got no vein, the results are almost the same. So it's still very controversial whether we want to send a patient to undergo endovascular or open surgery. But in our practices, if you've got a huge wound, then we need to have a one inline flow down to the foot and try to save the foot and think bypass is the best answer. But if you've got a small gangrene and patients at high risk and stenosis not so severe, maybe endovascular is the answer. So right now, both are still open to debate. So this is just an example of a patient with a superficial femoral artery occlusion. You find profound femoral arteries goes down to reconstitute popliteal artery. And patients like this, endovascular therapy is very simple, done under sedation. And then patient presents with gangrene. We took out, after revascularization, we took out a toe and then the wound healed well. However, sometimes patients got very long occlusion. That is a 90-year-old woman who is quite fit. Also, leg gangrene, you find that patients got superficial femoral artery occlusion. So we did a long bypass from superficial femoral artery right down to the anterior tibial artery, and then and certain result is very good. The ulcer healed, and this bypass can last for a long time. So which to choose is still a bit controversial, depending on patient's morbidity and also severity of the wound. Not to forget that peripheral neuropathy is also one source of pain for the patient. In how do you diagnose peripheral neuropathy? Well, all the pulses are palpable, and this patient actually has got either numbness and tingling, severe pain, or maybe ulcer over the pressure area. So this is actually due to peripheral neuropathy, and these patients do not need revascularization. Basically, we need to send to a podiatrist, address the wound, and then this ulcers will heal. Now, ladies and gentlemen, the important thing to know is that when you have got ischemic limb with a gangrene, etc., do not try to take out the gangrene. Try to revascularize first. Because once you open up the portal entry, the bacteria goes up to the level of the metatarsal, there isn't anything one can do. Even you revascularize, you still need to go for a below knee amputation. So one should try to revascularize before taking out the toes. So, of course, we want to avoid tragedies like this, because once patient has got an issue in one limb, in 2 years' time, the contralateral limb will be involved. And if you were to have a patient like this, I think quality of life is horrible for the patient. So important to remind us this saying by Paulo Coelho, Brazilian writer who wrote this Alchemist, if you know. And it says that don't allow your wounds to transform you into someone you are not. So when we look at patients with no legs and all that, always remember, once upon a time they were a teacher, they were headmaster, they were military officer commanding the whole thing, and right now they are, assigned to a wheelchair, needing help. It's really pathetic. With that, I thank you very much.
Okay, so I've got 3 cases that I would like to share here today. We'll probably spend a little bit more on the first 2 cases because they are a little bit more common in our day-to-day practice. So PAD actually essentially involves arterial disease involving vascular beds other than that of the coronary circulation. So you can get it in your carotids, you can get it in the upper limbs, lower limbs, in the renal arteries as well. The cases that I'm going to present today, all 3 involves the lower extremity arteries. So let's start off with the first case. So we've got a 68-year-old male. He has got diabetes, hypertension. He suffered a myocardial infarction 8 years ago in which a stent was inserted. He's obese with a BMI of 25. He still actively smokes. His LDL is 2.4 and he has a HbA1c of 6.3. So looking at all this information, we can conclude 2 things. He still has got a lot of room for improvement in terms of his risk factor modification. And he probably doesn't have a nagging wife like Dr. Navin's patient. Yeah. So now, if we go to the next slide, if we look at his medication, so these are his meds that he's on. He's on metformin for his diabetes. He's on aspirin for the coronary artery disease. He takes atorvastatin for his cholesterol, and he's on perindopril and bisoprolol both for the ischemic heart disease as well as the hypertension. So he comes for his routine physical checkup, and upon examination of him, he says that he's been actually experiencing left calf pain for the past 1 month. So this gentleman is actually fairly active. He goes for walks at least 2 to 3 times a week at the running track. So he does about 3 to 5 rounds, which comes up to about 2 km. But he says for the past 1 month, he's been noticing that he's got to stop at the 2nd or 3rd round. He's got to rest for a little bit before continuing his walks. So on physical examination, we don't see any gross abnormalities in both of his lower limbs. So what should we do next for this gentleman? All right. It's something actually fairly very simple that we can do in the clinics itself, which is actually to just examine his lower limb pulses. Okay, and why is this important, right? So just to recap back, this is, I think Dr. Liu has gone through this. Now, why is it very important to actually examine the lower limb pulses? This was actually a study that was done in Denmark, and they looked at about 18,000 patients, and they found that a simple act of actually examining the lower limb pulses has got a sensitivity and a specificity of 70% to exclude or pick up lower artery disease. But more importantly, what this study found out, examining the pulse has got a negative predictive value of 95%, which means that if you can feel the patient's pulse, most likely he or she does not have lower extremity arterial disease. Okay, so it's very important. And if you do not have time during your clinic session, at least try to feel both the dorsalis pedis as well as the posterior tibialis artery. Now, this is important because at least 10% of the population, they do not have a dorsalis pedis artery. Yeah, whereas I think only 2% of the population do not have a posterior tibialis artery. So it's very important to examine both of these pulses. Okay? So in this gentleman, what we found was that we were actually unable to palpate both the dorsalis pedis and the posterior tibialis, but it's on the left foot, sorry, it's not on the right foot. So what investigation should be done next? Should we do an ankle brachial index? Should we do a CT angiogram or an MR of the lower limbs? Well, the first line screening tool and the most easiest tool to be done is actually looking at the ankle brachial index. Yeah? So this gives us two information. It gives us the diagnosis whether this patient actually does have arterial disease of the lower limbs. So for this gentleman, we found that his ABI on the left-hand side was 0.8. So that comes under mild arterial obstruction. The other important information that an ABI gives us actually is it gives us the prognostic value. I think this slide was also shown by Dr. Liu. If you look at the x-axis over there, the x-axis is the ABI index and the y-axis is the incidence of cardiovascular mortality. So if you look, the lower the ABI value is, the higher the risk of a patient getting cardiovascular event in the future. Right? So it gives us two very important information. So based on this clinical presentation, what is the most likely diagnosis? Based on all the investigation findings, physical examination, I would say that this patient most likely has got intermittent claudication. Okay, so how do we then treat them? So this is actually the Fontaine classification, and if you see this stage 2B, 3, and stage 4, we might consider revascularizing the patient depending whether it's an open surgery or endovascularly. But this gentleman falls in stage 2. The reason being is because he is still able to walk about 2 to 3 rounds, which comes up to about 1.2 km. All right. So for him, what we did was we told him that he did not require any invasive procedure. That he just needs to be on medication, he needs to properly control his risk factors, he needs to stop smoking. Now, he was very concerned that he was going to lose his limbs because he said to us that you're saying that I've got a block in my artery and you're not going to do anything about it. So he was very concerned about this. So how do we address his concern? Now, if you look at this, as Dr. Liu had also mentioned previously, the limb prognosis for a patient with intermittent claudication is very good. So in the next 5 years, 80% of them would not have much symptoms. Only 10 to 20% of them may progress to worsening symptoms, and about 2 to 5% of them may develop. Now, the rate of amputation for patients with intermittent claudication is about 1 to 3%. So we can actually reassure him to tell him that his prognosis of him losing the limb is quite low, right? He's quite safe, but he needs to take care of his risk factor because if you look on the on the left-hand side, his cardiovascular outcomes when he has got intermittent claudication is not that good. At least 25% of them can get a cardiovascular event in the next 5 years. Okay, so he was aggressively treated with medical therapy. What we did for him was we added ezetimibe to his existing Lipitor. We wanted to bring down his LDL cholesterol at least to 1.8 and below. When we also gave him silastazole 100 milligrams twice a day. So silastazole is actually a phosphodiesterase 3 inhibitor. It works in 2 ways in this group of patients. Number one, it inhibits platelet aggregation. And it also acts by causing a little bit of vasodilatation, which actually improves the blood flow. And studies have been shown that silastazole actually improves walking distance in this group of patients. The other thing that's very important in patients with intermittent claudication is to actually put them on a supervised exercise program. Yeah, so this includes something between 30 to 45 minutes of walking on the treadmill at moderate intensity, and they should do this. Okay, so the other thing that we had asked him to do was to stop smoking, of course, yeah. So we followed him up closely. And he was reviewed after 1 month. His symptoms had improved dramatically. His LDL had gone on to 1.2 and he had also stopped smoking. Unfortunately, 2 years later, he comes back. His symptoms had returned and this time it got worse. He was only able to walk for a distance of about 50 meters. So we were a little bit curious as to why this may have happened, but on further history, talking to him, he found out that he was actually started to smoke back again. So in this case, we actually decided, after discussion, we went in for a revascularization. So what we see here is actually he's got 2 occlusion. The pictures in the middle show that he's got a severe lesion at the mid SFA, and he's also got a total occlusion of the distal SFA. So this is a picture after we have done, yeah. So we've established flow all the way down to the knee. So he's been keeping well since then. He has stopped smoking. We've put him on an antiplatelet as well as rivaroxaban. So as you may know, rivaroxaban is actually anticoagulation. Initially, it was made for stroke prevention in patients with AF. And we also do give them in some cases of deep vein thrombosis as well. But there was a study that was done in 2020 which shows that if you put the patient on low-dose rivaroxaban as well as a single antiplatelet, the dose of 2.5 milligram a day, it actually reduces the chance of them getting further symptoms and requiring repeat revascularization. So he's been keeping well since then.
Based on the ABSI, what would be their cutoff ratio for us to refer to vascular surgeon or to endocrinologist or to therapist? What is the cutoff points based on the ABI?
Well, usually a normal ABI is 0.9 to 1.3. So anything less than 0.9 indicates that the patient has got some form of peripheral artery disease. If they've got an ABI that is more than 1.3, that also may indicate that they have arterial disease because the vessels become more calcified, so you get a higher ABI reading. So anything above 1.3 or less than 0.9.
Can hyperbaric oxygen treatment help in peripheral arterial disease ulcer?
Maybe I'll get Dr. Liu to answer this.
Yeah, I was trying to impress upon my medical students that every disease, there's a main therapy and there's an adjuvant therapy, and one should not be confused. For instance, breast cancer, the main therapy is mastectomy, adjuvant therapy is hormonal therapy, chemotherapy, radiotherapy. When you have peripheral artery disease, the main thing is you have to revascularize and not maggot therapy, hyperbaric oxygen therapy, and things like that. It doesn't work because people get confused. So I always tell my patient that you have got peripheral artery disease, there's no blood going down. You can buy the best, whatever regenerating agent you apply on the wound, you're wasting your money. It's just like sawah padi. Sawah padi tak ada air, you nak cucuk tanam, baja, whatever you buy from Russia, from Ukraine, it doesn't work. You have to bring the blood down. You can wash with tap water, it will all heal. So always do not get confused. There is main therapy, there's an adjuvant therapy, and you have to follow that way. Hyperbaric oxygen, it does not work because I was from the army. I used to run the hyperbaric chamber in Lumon Hospital. And so what happened is, for hyperbaric to work, you find that our hemoglobin is about 98.4% saturated with oxygen. Now, if you have a hyperbaric oxygen, what happens is, the oxygen dissolves into the plasma, and then that actually increases oxygen delivered to the tissue. Your vessel is blocked. How does the plasma reach the ulcer? It's a waste of money.
How much does stopping cigarettes help to remove intermittent claudication? And would you start antiplatelet therapy besides the statins?
Yes, so cigarette smoking has been shown to contribute to, if I'm not mistaken, about 20% of cases with PAD. And this gentleman had already been on an aspirin. So if he was not, yes, I would consider putting him on an aspirin treatment.
How much does stopping cigarette smoking help?
I can't think of a percentage, but I think it drastically would reduce the symptoms, yeah.
For endovascular therapy, is it stent or balloon only? For your patient, did you have to stent or you just ballooned it?
For this gentleman, we actually use a drug-coated balloon. So I think nowadays, I think it's much better to use a drug-coated balloon than stents because these patients tend to come back again after 2 to 3 years sometimes, and it's much easier to actually perform a repeated procedure in them if they do not have a stent.
In high-risk patients, any role for routine early CT peripheral angiogram to pick up significant peripheral arterial disease?
Yeah, in my opinion, no, because I think the most easy test to be done is an ankle brachial index. A CT angio of the lower limbs is usually done if we would want to plan for a revas procedure. So to answer it, no, we would just do an ABI for it.